I'm the moderator of this session, Dr. Hina from Islamabad. So the first speaker is Shehzadi Fatma Hassan, and she'll be speaking on solar retinopathy. Albert.
Eye Care Hospital, Dera Ghazi Khan, under the supervision of Dr. Muhammad Rashid Qureshi. There is central macular involvement, and on OCT, there are diverse presentations. Outcomes vary according to age, light intensity, and durations of exposure. Retinal phototoxic injury is caused by direct sunlight, artificial light, or occupational exposure. There is bilateral asymmetric symptoms like central scotoma, photophobia, metamorphopsia, decreased visual acuity, and headache. Visual recovery varies. Persistent ellipsoid zone damage may persist. History and OCT are essential for diagnosis. It is a rare photochemical injury, and mainly foveal outer retina is involved. Recovery takes about 3 to 6 months. Structural changes may persist. As you can see in the diagram, there are outer retinal layers that are affected in solar retinopathy, particularly the photoreceptor layer, ellipsoid zone, and the RPE. In acute cases, we see yellowish foveal spot. Unusual causes other than sun exposure include clay ovens, welding arcs, laser pointers, prolonged surgery, light, laser hair removal devices, and microscope light. Prevention is by protective goggles and solar filters. Our first case of a tandoor baker, a 61-year-old tandoor baker presented with gradual central blurring and decreased best corrected visual acuity. Initially, he denied any light exposure, but on OCT review and targeted cushioning revealed 30 years of light exposure of tandoor work. OCT revealed outer retinal disruption with epiretinal membrane and central thinning. Patient was observed and counseled on prevention. On 6-month follow-up, there was modest improvement due to chronic exposure. As you can see in the OCT, there is central thinning and disruption of outer retinal layers, particularly the ellipsoid zone, and you can also see the thin epiretinal membrane. Another case is of a teenager. A 16-year-old male presented with repeated laser exposure by a child at home. He presented with sudden blurring and decreased best corrected visual acuity. OCT revealed outer retinal disruption, including the RPE and the ellipsoid zone. Patient was reassured and was told to avoid laser exposure. On 1-month follow-up, there was notable improvement because of acute onset, young age, and less exposure duration. As you can see in the OCT, there is disruption of outer retinal layers. Another case is of a laser hair removal operator, 21-year-old, presented with decreased best corrected visual acuity after accidental laser exposure. While handling laser device, OCT revealed outer retinal disruption, particularly the ellipsoid zone. Patient was reassured and was strongly advised to use certified protective goggles by himself and his clients as well. During all laser-based procedures, on 6-month follow-up, there was only partial improvement. As you can see on the OCT, there is disruption of outer retinal layers. Another case is of a welder. 21-year-old welder who just started working at a welding workshop presented with decreased visual acuity, and there was disruption of outer retinal layers on the OCT. Fundus was normal, best corrected visual acuity was mildly reduced. Patient was reassured and was counseled to use protective eyewear. On 6-month follow-up, his vision was stable. As you can see on the OCT, there is disruption of RPE and the ellipsoid zone. Foveal architecture is preserved, no edema was present. Another case is of a 20-year-old male who presented with acute blur 1 day post-eclipse. On fundus, there was small yellowish subfoveal spot. Ellipsoid zone disruption was present on OCT. Subtle RP irregularity was also present. The patient was reassured and was counseled on sun safety. No treatment was given. On 6-month follow-up, the vision was stable and no OCT change was seen. Fundus may look subtle. OCT is essential for diagnosis. As you can see in the OCT, there's the disruption of outer retinal layers. All ages are affected. Severity depends on exposure, intensity, and duration. Risk factors include ocular media clarity, blue light risk, and its wavelength is damaging an individual's susceptibility. Photochemical injury affects the photoreceptors, RP, and the ellipsoid zone, and we see changes in these layers on the OCT. Reassurance and prevention are critical as this is usually self-limiting. Corticosteroids and antioxidants have limited role in cases where there are inflammatory changes like cystoid changes or PED. Partial recovery is common, but overall prognosis is good as in our case. In chronic long-term exposure in older individuals, their extent of retinal damage and negligible improvement is seen. Structural defects may persist and persistent scotomas are seen. In acute short-term cases, in younger patients, there is localized outer retinal disruption, rapid recovery, and prognosis is usually good. It is under-recognized and can occur without direct sun gazing. Sun safety and occupational safety is important. In welders, laser operators, in occupational laser pointer, and occupational safety is very important. Photic injury is preventable, and this makes patient education one of the most important key and important roles by eye care professionals. OCT is essential, and good history is important and often uncovers exposures the patient didn't recall. I would like to thank Dr. Muhammad Rashid Qureshi for his support and motivation throughout the presentation preparation. Thank you.
Thank you, Shehzadi. One shout out to Saad Aziz. Were you here?
Not because of the case, but because of the thought process that goes into the mind of a clinician every time they encounter such rare case presentations. So moving on. So there are no financial disclosures to be made. So our patient was a 34-year-old female who came to my clinic, and her main complaint was that, Dr. Saab, when I put my hand in front of the right eye, I can see everything clearly through the left eye. But when I put my hand in front of the left eye, I can see everything clearly from the front. But there is something definitely present on the upper right part of the right eye. And it has been there for the past 2 to 3 weeks. It is over there day and night. It's not going anywhere. And it has troubled me so much so that I'm unable to carry out my daily activities. I'm not going to the office. I'm not doing my pick and drop duties for the kids. So it is troubling me. So this is where the first thought process triggered in my mind that, okay, she is complaining of something wrong in the upper right part of the right eye, which means that she can have a right-sided supratemporal quadrantanopia, which means that whatever the pathology is, it is somewhere anterior to the chiasm, maybe on the optic nerve, somewhere on the optic nerve head, could be the macula, can be a localized retinal detachment. So I took a detailed history from the patient, both systemic and ocular, but I did not really find anything significant over there. So we moved on with the visual examination. The best corrected visual acuity was 6/6 in both eyes. The pressures were normal. The left side examination, anterior and posterior, both were unremarkable. On the right side, I even did gonioscopy just to see if there is anything wrong in the angles, but I could not find anything over there. So just when I focused the posterior segment of the right eye, this is what I saw. So a yellow-white lesion about 4 disc diameter in size, definitely subretinal, with this horizontal streak of blood encroaching the infranasal juxtafoveal area and infratemporal to the optic disc. This is where the second thought process triggered. Okay, now we are dealing with two different things. I have to establish a differential diagnosis over here, and I also have to counsel the patient that there is a possibility that we might not be just dealing with sight-threatening complications, but also life-threatening complications over here. Because this is a subretinal tumor, And there are multiple possibilities that are present over here. So we explained everything about this lesion to the patient, and we also explained her about that we have to go for an extensive workup just so we can be sure about the treatment process and everything. And fortunately, she agreed to all of it. So these were my differentials: choroidal melanoma, capillary hemangioma, and osteoma because it was yellow-white in color. METS maybe, although her age was not coinciding with it, but still we had to rule it out. And choroidal neovascularization associated with any of these things. So the systemic workup that I did was unremarkable, so I have not really included in it. We did full blood count, ESR, chest X-ray, abdominal and pelvic ultrasounds, and there was nothing significant over there. So we stopped over there and shifted to ophthalmic investigations, which included, first of all, OCT macula. This is the left eye, nothing remarkable over here. This is the right eye. So this is a type 1 CNV on OCT macula. The lesion is over here, definitely in the choroid, a breach in the brook, some subretinal fluid over here. So type 1 CNV. Moving on to the OCT angiogram, you can see that the superficial plexus is spared, the deeper plexus is involved right now, and it is coinciding with the OCT macula. We had an FFA done as well because a melanoma is supposed to show dual circulation, but we did not see any such thing over here. This coincides with occult CNV, which is type 1 CNV on the OCT macula. The peripheries I have not included because they were also unremarkable. So when I saw the FFA, I had my doubts on melanoma. So, but we had to rule it out. So we had a B-scan ultrasound done as well. Now this is the B-scan ultrasound of this patient. You can see that there is this hyperechogenicity, which is this calcification, and it is giving the impression of dual optic nerve shadow, which is pathognomonic for a choroidal osteoma. So I immediately called our patient and I told her to get a CT scan brain with contrast done, and this is what we found. This hyperdense plaque just adjacent to the optic nerve, and the hyperdensity is well in line with the hyperdensity of the bones of the skull. So based on these findings, we established the diagnosis of choroidal neovascularization secondary to choroidal osteoma. So at this point, I immediately opened up the literature just to see that how are we going to proceed further. So we found some very interesting facts that the first case was reported back in 1978, and ever since there have been less than 150 cases reported on choroidal osteoma. And more interestingly, it has been less than 110 cases of CNV secondary to osteoma. That is how rare this case presentation is. So we found multiple strategies to manage this case, which included intravitreal anti-VEGF injections, photodynamic therapy, and argon green laser to the edges of the tumor. All of them seem to work in the literature, but since we were dealing with this pathology over here in Pakistan, the only option that we had over here was intravitreal injections. So we started off with loading dose of 3-monthly intravitreal aflibercept. The patient responded well to it. She was young, and so this is the picture after the 3 injections that we gave. She was very happy, symptom-free. But you can see that the CNV has settled, but the lesion is still over there. So the patient was happy for another 5 months until she came back to us again with the same symptoms. Again, the fluid has begun to develop over here, and definitely because of the CNV secondary to it. So this is where the third thought process triggered, that now we have to counsel the patient, this young patient, about recurrences, and they are likely to happen for the rest of her life. And because CNVs behave in this manner everywhere, if it is a CNV, it will keep on recovering. We will have to give her injections. So our patient was very optimistic. She said, you know what to do. You just keep on going with it. So we gave another injection of aflibercept injection. She came back again with the same symptoms. So this time, I approached some senior vitreoretinal surgeons in Lahore, discussed the case with them, and they told us to change the intravitreal injection to another one and include a steroid injection with it as well. So this is what we did. And to date, the patient is symptom-free. It has been about 4 months. She comes for regular follow-ups, but we have told her about the recurrences, and she is optimistic about it. So let's see. These are the treatment options that I have discussed. These were some of our limitations. I called some of my friends at Aahan Hospital. They told us that they have ICGA available, but photodynamic therapy, unfortunately, is still not available over here. This is the flowchart of the thought process that I was keen to make. Every portion of this flowchart, I believe, is very important in this process. And finally, the take-home message. History gives us the first clue. Examination determines urgency. But I think for me, this was the most important point. Effective communication with empathy. We were dealing with a young patient who has to receive intravitreal injections for the rest of her life, maybe. And this is a tumor. I mean, when we tell a young patient about a tumor, they are taken aback. It is very difficult for them to digest all of this information. So, recurrence is not a failure. This also has to be mentioned to the patient that it's a part of the treatment. It does happen. This is what the disease process is about. But we will deal with it. This is what I told the patient. And she comes for regular follow-ups. And we are hopeful that we will manage it. And follow-up is definitely treatment. Thank you very much.
Brilliant. Thank you.
Assalamu alaikum. I am Dr. Shahzadi Fatma Hassan, graduate of Frontier Medical College, Aptabad. I have done Part 1 in ophthalmology and currently working as a medical officer at Al Qasim Eye Care Hospital, Dera Ghazi Khan, under the supervision of Dr. Muhammad Rashid Qureshi. The topic of my presentation is Tvot Kayanagi Harada disease. It is a rare autoimmune multisystem disorder that targets melanocyte rich tissues, particularly eyes, ears, skin, and meninges. And it typically presents as granulomatous panuveitis. The disease goes through 4 classical phases: prodromal with neurological and auditory manifestations, acute uveitic in which we see uveitis, RD, and Dillon-Foot's nodules, convalescent with integumentary sign, sunset glow, fundus, and Chijura sign, and chronic recurrent in which we see anterior eukaryouveitis exacerbation. Patients typically present with bilateral granulomatous uveitis with systemic signs like neurological, auditory, or integumentary involvement may or may not be present. In our case, diffuse alopecia before ocular symptoms and neurological or auditory manifestations were absent. This highlights the importance of early recognition as prompt high-dose steroids can prevent chronic visual loss. The diagnostic criteria helps us classify VKH into complete, incomplete, or probable forms, guiding both diagnosis and management. It includes absence of ocular trauma or ocular disease, bilateral uveitis, neurological signs, and integumentary signs. Our patient had bilateral uveitis with integumentary signs, and we labeled it as incomplete uveitis, VKH. For your understanding, I've added a diagram of sunset glow fundus with Dillon-Foot's nodules. The nodules you can see are Dillon-Foot's nodules seen in VKH, in the convalescent phase of VKH. These features are often visible weeks to months after the disease. A 50-year-old patient had 3 weeks of painless bilateral visual loss with prior febrile illness leading to diffuse alopecia. Examination revealed mild anterior uveitis and serous RD. On OCT, there was full retinal disruption, multilobular subretinal fluid, hyperreflective dots were seen, and choroidal thickening was present. The diagnosis of incomplete VKH was made and high-dose corticosteroids were started. Tapered gradually over 3 to 6 months and low-dose maintenance to prevent relapse. The outcome was excellent with best-corrected visual acuity improved and stable vision at 9 months. As you can see in the OCT, there is multilobular serous RD involving the macula and paramacular region, disruption of foveal contour, Full thickness RD hyperreflexive subretinal dots can be seen and correspond to inflammatory cell aggregates, and diffuse choroidal thickening were noted. OCT findings are highly suggestive of active VQH as their inflammatory signs like hyperreflective dots and serous retinal detachment. OCT findings are highly suggestive of active VKH and essential for diagnosis and monitoring disease activity. VKH is a rare autoimmune disorder triggered by T-cell mediated attack on melanocyte antigens sometime following infections through molecular mimicry. VKH is a rare autoimmune disorder triggered by T-cell mediated attack on melanocytes sometime following infections through molecular mimicry. The genetic susceptibility is important. Early inflammatory signs like alopecia, poliosis, and vitiligo are rare and usually appear weeks to months after ocular inflammation. When they appear early, as in our case, they indicate rapid melanocyte destruction, possibly triggered by molecular mimicry and autoimmunity. Differential diagnosis includes sarcoidosis, tuberculosis, syphilis, sympathetic ophthalmia, as there is bilateral uveitis in all these cases. Multimodal imaging is essential. OCT is important as it shows RD, hyperreflexive subretinal dots, diffuse choroidal thickening, and vitreoretinal interface changes. FFA shows multiple pinpoint lesions with late pooling in acute uveitic phase. On OCT, there is reduced macular and choriocapillaire vessel density in active disease, foveal avascular zone enlargement in remission. These help diagnose, distinguish, treat, and predict prognosis of the disease. High dose systemic corticosteroids are the mainstay. Early aggressive therapy improves outcomes and reduces chronic recurrence. Gradual tapering is essential, and low dose maintenance prevents relapse. Rapid tapering risks recurrent inflammation, cataract, glaucoma, subretinal fibrosis, and choroidal neovascularization. Injective immunosuppressants are also given, like cyclosporin, methotrexate. Adalimumab may improve dermatological outcomes. Special considerations apply in pregnancy. Our patient vision recovered rapidly, best corrected visual acuity reaching 6/9 within 1 month, and remains stable at 9 months. VKH carries lifelong risk of recurrence, so long-term follow-up is essential. Complications may include cataract, glaucoma, subretinal fibrosis, optic nerve ischemia, vitreous hemorrhage. Takeaways include early alopecia may precede ocular symptoms, neurological signs may be absent despite bilateral uveitis. Multimodal imaging is important, especially OCT, as in our case. High-dose corticosteroids with slow tapering is important to prevent relapse and maintain vision. To conclude, VKH is a multisystem autoimmune disorder affecting eyes, skin, meninges, and the inner ear. Early corticosteroid therapy prevents relapse. Clinical response may help confirm the diagnosis even when full imaging is unavailable. Awareness of systemic signs and atypical presentation is essential to differentiate VKH from other causes of bilateral uveitis. I would like to thank Dr. Muhammad Rashid Qureshi for his motivation and support. Thank you.
For the kind invitation, thank for the organizer, thank you for the moderator for the introduction. This is my third time in Lahore in the same conference. Thanks for all my dear friends for inviting me. So I will talk about ultra-wide field imaging, and it's something maybe most of you know it, and it's simple. But we will highlight some points about that. So knowing what is seven-field imaging and what is the advantage of ultra-wide field imaging over the seven-field, and what is the pros and cons of ultra-wide field over the seven-field. Before we used to use the conventional fundus camera to see, and that was only we are covering about 50% degree of the fundus. So we are missing a lot before about pathology in the periphery. Then the era of the seven fields came. It was a seven distinct image combined together, and you can see in the top and the lower also photograph that have a high resolution, and it have a panoramic view of the retina. This one, it was an improvement and give us also some sort of seeing a pathology and in a high resolution photo of this seven field imaging. But later on, we are coming also to the ultra wide field. Before that, I think, but just I want to show this the pandas, how it looks the photo, and the seven field where it will covers. I don't know. You can see only that area it's covering. So it's not all. So this area we are not seeing beyond that seven field. And then the ultra wide field now, which is available, and it's really a good achievement in our work. So it's a broader wide field compared to the traditional, visualize even up to 200 degrees of the retina, providing more comprehensive assessment of the eye. And the most important things that we want to concentrate and to talk about is detections of pathology that may be missed with standard techniques. And we will show some of the cases later on. Ultra wide field imaging options, there is a lot of machines. I will not go because I don't want to mention something here. I don't have any financial interest, but there is a lot of machines that they are now available in the market, and they are varying from one to another one by the area they are covering. And sometimes if there is a soda imaging or the laser techniques, whatever the different things they are using to have this type of wide field image. Also, there is a difference between both of them. It is can be sent or anyone wants. It's available for anyone just to see the difference between different all these machines. Diagnostic accuracy is very important. Ultra wide field, the expensive one. I know it's field, but it's ultra wide imaging enhance detection of peripheral retinal pathologies. This is the most important I mentioned early. It can be like breaks in the periphery, or sometimes even a diabetic retinopathy or something that we are not seeing, especially in about 15% or 20% sometimes, the diabetic retinopathy available in the periphery, and we are missing it if you are concentrating on the center only. This is a comparative study finding sensitivity and specificity difference between both. So if in case of ultra wide field imaging, the sensitivity is high, about 92%, while the seven field it's around 87, and the specificity is 80% in ultra wide field, less and compared to wide field. So ultra wide field imaging versus EDR field in diabetic retinopathy. This is the one I told you in the beginning. So you can see here in this fluorescein cases, the ultra wide field, which show here in this area or in this area. And you can see the pathology here and here. We are going to miss if we don't have this ultra wide field. So this is a neovascularization elsewhere. So we can detect it only if we are having the ultra wide field imaging. So the main advantage of ultra wide imaging, if done with assistance of the dedicated image grading center, increase diabetic retinopathy identification frequency by twofold. So it is very important. Reduce acquisition time by more than half. So it will be safe, especially for those centers they are having a load of the patient. It will be very difficult to assess all the patient and take a time with them. So relevant for a very large, busy center with a huge patient flow. This is again another patient, post-laser proliferative diabetic retinopathy. We can see how the laser it show. And also you can see the proliferative diabetic retinopathy in the center. It can be detected easily with wide field and give you a comparison what is going on in the center periphery. This is a branch retinal vein occlusion. You can see if we are not having this and we are only concentrating in the center, we will not see the ischemia which is available in the periphery. So here we can see the ischemic changes. And only the 7 field, it will be cover only this one. So this one you will be missing if you are not having the ultra wide field imaging. Also, it can be used for proliferative diabetic retinopathy identification, either if there is a neovascularization on the disc or in the periphery. So it can be one shot, and then you are able to diagnose without going dilatation. Even this, you can do it without dilatation. So it's very fast, less consumer of the time for you and for the patient. Peripheral vascular leakage also, this one either in the disc or in the late phase. It can be also seen with wide field imaging. So this is one of study done in United Arab Emirates, and we do it to see if this ultra wide field imaging for telemedicine retinopathy screening using ultra wide field by my dear friend Dr. Nazim Al Hussein in the private sector, one of the big private sectors. And the result was the present study has shown the effectiveness of diabetic retinopathy screening using ultra-wide field fundus camera. It has shown the effectiveness of 3 trained nursing personnel taking fundus image. This model can be replicated in any private multi-specialty hospital and reduce the burden of diabetic retinopathy screening in retina clinic, and enhance early detection of treatable diabetic retinopathy. Another study also done there, and also this one to see the ultrawide fundus pathocan is to replace early treatment diabetic retinopathy study in case of 7 field photography, and also in conclusions, even in ETDR's standard and ultrawide photography may have a potential acceptable agreement on diabetic retinopathy grading of severity and effectively can be detect diabetic retinopathy lesions outside of the area of ATDR7, adding to its advantage of understanding of progression of diabetic retinopathy. So the take-home message, ultra-wide field demonstrate need to image periphery could improve management in up to 5 to 10%, even to 20%, which is the same percentage that when we are missing diagnosis of diabetic retinopathy in the periphery. Conventional fundus imaging with 30-degree camera ATDR7 field never designed to evaluate the periphery, but miss significant lesion in only about 15 to 20% of cases. Current generation fundus camera visualization beyond the equator possible in most of cases. Likelihood of missing clinical significant lesion very low. Thank you very much, and I would like to invite you also to our conference, which is 8th MIOM in Dubai. It will be in 30th of October to 1st of November 2026. Thank you again. Thank you very much.
I know the scientific program said type 4 MNV, but I'm starting with a term called central posterior hyaloid fibrosis. I do have a point here, so I'll just ask for you to just bear with me for a while. So I work as a lead of retinal imaging centers to 5 imaging centers that come under the umbrella of Amanat Eye Hospital. And I not only report my own scans, but I report every single person that presents because we act as a tertiary referral point. So I report all scans that come to Amanat. And for somebody who's interested in retinal imaging, that's a gift by God. So my whole day goes around looking at images. And the more you do so, I used to say that, when I started, I used 1 in every 10th scan was something that would show me something I'd never seen before. And that figure, that frequency has not changed. So 1 in every 10th scan still shows me something that I've never seen before. It's actually you're looking more into the OCT images, and there's a never-ending learning process. So just to draw your attention to CNV, we know it's the most common cause of loss of vision in adults in the developing world. The exact etiology of why the whole process happens, we are still not sure, but more and more emphasis is being made on the vitreoretinal interface, and we find that there are things there that are going on, processes that we still can't explain. For example, vitreomacular adhesion has been seen more frequently in patients with exudative AMD than in controls. Now, this is also debatable. I'll be citing another study, but that has another interesting outlook. Also, posterior vitreous detachment then conversely, they said, may actually prevent against the formation of exudative AMD. And VMA may promote it because that's an extrapolation from the finding that VMA is seen more frequently. And then obviously the fact whether the traction is there or the adhesion is there, we all know in our diabetic patients and our uveitis patients as well that does impact our response to treatment, whether it's with anti-VEGF therapy or anything else. Now, the exact role of vitreoretinal interface abnormalities in the pathophysiology of CNV, and conversely, whether the CNV has an effect on the vitreoretinal interface is still very poorly understood. So as I said, going back to my story, when you do so many scans in a day, you start to pick up findings that are peculiar. And I'm very, very honored and very blessed to be surrounded by giants of retinal imaging. And there are like an email away or a phone call away, so you can always refer to them. Ye effort jo hai na, especially for the juniors, ye aapne karni hai. It's just very easy to see a scan, say, oh, well, I don't get this part, let's go on to the next scan. Or see a patient like for Dr. Saad and say, oh, well, something white, mujhe samajh nahi aaya, okay, kisi consultant ko refer kar de. You have to stick to what you're seeing. And in that process is really where all the learning lies post your fellowship exam and post everything else. So I saw this peculiar simply, you see this huge CNV lesion in here. You've got subretinal fibrosis, almost a gone eye as far as treatment is concerned. But what's going on over here at the vitreoretinal interface? So it's abnormal, triangular-shaped hyperreflectivity. Now, since I had to write a report and sign my name on it, I had to come up with the kind of English terminology that would describe this. And it just went on loss of wrinkling of the inner retinal surface. Don't know what to name it, right? Sent it to a consultant who said, okay, I've never seen anything like this. Brandon Lujan, USA में Portland Oregon Eye Institute के थे. And he said, okay, let's put this aside and see. After a couple of weeks, we saw another patient, advanced AMD case, same fibrosis pattern. And then he said, okay, now that you have two cases, why don't you write this up? लेकिन हम तो पाकिस्तानी हैं, तो हम तो कुछ करते नहीं हैं उसका, so I just put it aside. After a couple of weeks again, I saw another case. That is when you start to get intrigued over what this is and why it's never been published before. So why am I calling this different from other abnormalities is that the filled-in appearance of the foveolar depression, you see? And we defined it as thickening of the posterior hyaloid membrane at the central point of persistent attachment to the foveola, leading to the appearance of a filled-in foveolar depression. And we named it central posterior hyaloid fibrosis. Now, why I'm calling this different is when you have the subtlest, you say, why can't we call this VMT? But with the subtlest VMT, the first thing that goes is your foveal concavity, which even in this most advanced case is still restored. And with epiretinal membranes, the subtlest epiretinal membrane would lead to wrinkling of the inner retinal surface, which you're not seeing in this particular change. So there's something going on which is different too, and exclusively would happen with cases advanced CNV. So alhamdulillah, we were able to publish this as a novel OCT finding associated with choroidal neovascular membrane. This was published in the American Journal of Ophthalmology. It's in the case report, but this was actually a case series of about 5 patients that we could publish. And we termed, the pattern of the research was that it was a retrospective observational case series from all the patients that came to our clinic. These were the devices we were using in the different imaging centers that we have. We disregarded patients with pathologies which are known to influence vitreoretinal interface, which is uveitis or vitreoretinal surgeries or diabetic maculopathy. And when in doubt as to the CNV lesion, we would try and go for an FFA or an OCT angiogram to kind of delineate the choroidal neovascular network. So out of 12,634 eyes, we were able to exclude 571 due to other pathologies, and we came up with 5 cases of central posterior hyaloidal fibrosis. This is the figure from the paper that we published, and these were the 5 cases. So consistently, you can see the anatomical features that I described. Now, how it adds to the pathophysiology of MNV, we said that there appears to be a correlation of how a CNV might influence the vitreoretinal interface, right? Because there is a study done by Maggio. He first studied how many cases of exudative CNV have vitreomacular adhesion compared to age-matched controls with non-exudative CNV. He said there's no difference in frequency. But interestingly, he cited that the release of vitreomacular adhesion from patients with CNV was less frequent than spontaneous release in cases of age-matched controls. So he also was thinking on the lines of maybe this CNV makes it a little stickier, maybe it makes it a little less likely to release itself. And when you've got this proper adhesion going on with the CNV lesion at the back and all the biochemical processes, it was just a hypothesis at that stage that maybe the vitreoretinal interface is then being summoned in some way into the process. David Saraf, is a well-known retinal imaging specialist out of USA, and he described that vitreomacular traction itself, CIF vitreomacular traction without CNV, can influence through the Muller bouquet of cells. That's what he delineated at the foveal center, and can influence outer retinal changes. And he, from a small SRD to a cotton ball sign, and he defined a couple of changes regards to that as well. So we drew from those hypotheses, and we said that, there's a bidirectional relationship between CNV and perhaps CPHF. Now, after 6 months, our article was cited by another team in India that took it forward and said that, they had about 15 cases. Same definition was used, same terminology was used, and they said that they did study the visual outcomes, and they said that such lesions that do develop CPHF will naturally have a very low vision at presentation and very poor response to anti-VEGF therapy. And just lately, type 4 macular neovascularization has been defined by David Saraf, and central posterior hyaloid fibrosis is the defining factor. So he took up our research and defined type 4 MNV, which was published in Retina in September 2025. Very strong references have been made to the CPHF. The terminology has stayed the same. He has defined it a little differently. And their team, which includes Jemmy Chang and all these greats, actually went through the CPHF lesion with their OCT angiography softwares and found out that this is in fact part of the neovascular network. Whether it is originating from that very adhesion and going down, or it's originating from the choroid through the retinal tissue and going up, but they were able to recognize vascularization within the lesion that we spotted. So this is now being defined as a type 4 macular neovascularization, and I would like all of you to go and search this up on the internet and see what this is. So take-home message: never think of anything that interests you as something insignificant. You never know how far things can travel and how it can lead to, and that's just the exciting part about being a person of science in this era. I thank you all for your patient listening, and thank you. And we'll invite the next speaker, Dr. Huzaifa Rahman. Are you here? And he'll be talking on diabetic grading system.
As a resident doctor ST2 in Rochdale Infirmary Hospital, Greater Manchester, and I'm giving this presentation under the supervision of Mr. Chaudhry, that is a diabetic lead in Greater Manchester. So basically, just a brief summary of it. This is a system that is followed in UK for all the diabetic patients having diabetic retinopathy. Now, the global challenge for the word diabetic retinopathy remains the leading cause of preventable blindness in the working age adults worldwide, and it has created an urgent need for structured evidence-based screening programs. One of this program that is followed up in UK is called as Diabetic Eye Screening Program. Why this topic matters? Because Pakistan ranks as first among the world's highest nation for diabetes, which projections indicating a substantial increase in the coming years. Diabetic retinopathy causes significant visual disability in the working age population, profoundly affecting quality of life, economic productivity, and healthcare resources. So basically, early detection is something through systemic screening combined with correct triage and timely refer to appropriate services can prevent the majority of sight loss from diabetic retinopathy. The implementation of a new clinical guidelines based on a robust evidence is essential for improving patient outcomes and reducing the societal burden of diabetes-related blindness. Now, what is the diabetic eye screening program? So basically, this is a national program that was started in UK. So this offers annual retinal examination for all individuals with diabetes mellitus 8, 12 years and over to screen for any diabetic retinopathic changes. Now it involves advanced images, which include multi-field and ultra-field digital fundus photography. I think one of the presentation that was given over here, along with OCT in many regions for enhanced maculopathy detection. Now there's another system followed up here for feature-based grading, how to divide the diabetic retinopathy in further stages, and then integrated pathways. So whether this patient needs to be referred to the hospitalized services or not. Now diabetic eye screening program workflow overview. How does it work? So basically all registered diabetic patients in UK, they receive annual screening invitation through their GP practices, ensuring comprehensive population coverage. Imaging acquisition. So I already told there will be multi-field and ultra-wide field fundus photography that are captured by trained photographers with OCT imaging. Along with the feature-based grading. Now the interesting thing over here that in diabetic eye screening program, most of the people working over there, they are not doctors. So basically these are some of the guys that have done mostly OA level, they don't want to study further. So the government of the UK, they hire these people. Okay, you don't want to study further, we will hire you. We will teach you slit lamp things, and we will teach you some basic things about the diabetic retinopathy. And they use these guys, and they are supervised by the consultant ophthalmologist over there. And they made the triage over there. They try to divide the patients into the three categories that we will discuss further, and based on them, they will refer to the hospitalized services for further treatment. So the basic thing about this is a better triage. So most of the cases that we received over the UK, they are not the early diabetic changes. So most of the early changes are seen by the people over there. And if there is anything that needs to be seen by a consultant, they are just referred over there. Now, burden of diabetic retinopathy in Pakistan, 31% of the people, or 31.4% of the people with diabetes, 9.66 million diabetic retinopathy cases, and according to the International Diabetic Federation, almost 360 billion rupees that is annual cost for the diabetes in Pakistan. Now, evaluation for the diabetic retinopathy screening, how does it happen in UK? So basically, the routine examination that are done in the UK in the previous time. So most of the doctors working over there, if they find out that the patient is in advanced diabetic changes, proliferative diabetic with vitreous hemorrhage, because the patient won't know that in which state of diabetic retinopathy is it. They will come when they will have any vision problem, maybe caused by vitreous hemorrhage or the advanced stages. So they derived a system. They did something called as population-based program. They invite every diabetic patient yearly to go through some imaging, which include OCT and the ultra-wide field imaging. And then these patients are divided into some categories for diabetic retinopathy, that is FBG implementation, OCT integration, the systems used over there. Now, the feature-based diabetic grading overview. So R0, no retinopathy. R1, that is mild non-proliferative or background diabetic retinopathy with few microaneurysms, small hemorrhages. That can be easily managed by screening program by giving follow-up appointments and to discuss with the GPs over there. Now, R2 is pre-proliferative diabetic retinopathy that are divided into two things, that is low category, high risk category. High risk categories are referred to the hospitalized services over to us to have a look at it. And it includes venous bleeding, intraretinal microvascular abnormalities, extensive hemorrhages that requires closer monitoring, may be followed up after every 3 to 6 months. Now the R3, which include proliferative diabetic retinopathy, new vessel formation on disc elsewhere, pre-retina or vitreous hemorrhage, that can be classified as stable or active, that is mostly referred to the hospitalized services. And same goes for the maculopathy assessment, that is M0, no maculopathy, M maculopathy present. Now, R1, early non-proliferative diabetic retinopathy, clinical features over here, microaneurysms, hemorrhages, hard exudates, cotton wool spots, and venous changes. Regarding the R2 and R3, R2 there will be intraretinal microvascular abnormalities, extensive hemorrhages, venous abnormalities. R3 diabetic retinopathy, again active neovascularization at disc or elsewhere, pre-retinal or vitreous hemorrhage or tractional complication that might require surgical intervention. Maculopathy, this is divided as M0, M1, no maculopathy or maculopathy present, which includes exudates within 1 disc diameter of fovea. Retinal thickening at macula can be found on OCT or any visible macular pathology potentially threatening central vision. And OCT is also divided into 3 categories, that is OCT negative, normal macular architecture with no evidence of intraretinal or subretinal fluid, OCT borderline, that is not meeting criteria for significant edema and requires enhanced surveillance and possible repeat imaging, and OCD positive, which includes significant macular edema and macular thickening with intraretinal cyst, subretinal fluid, or central retinal thickness exceeding normal parameters. And OCD positive is something that requires referral from the diabetic eye screening program to the hospital eye services. Now, what are the things when diabetic eye screening program will refer the patient to us? It will be OCD positive, M1 we already discussed over there, or there will be any visual acuity drop. So basically, if there is any decrease in best corrected visual acuity of 6 or more over a 6/12 or 6 to 12 months period, suggested that there is some progressive maculopathy or there is active proliferative diabetic retinopathic changes, which includes NVD or NVE, if there is any vitreous hemorrhage or there is progressive DMO. And so the patients are referred to us in the hospital after the management. We also have to discharge back to the diabetic eye screening. So if there is R1, M1 that is totally stable, this can be patient discharged to the diabetic eye screening program, people over there. R3S that is treated proliferative diabetic retinopathy, treated with PRP or anti-VEGF therapy, or R2L, low or high risk categories. And regarding the follow-up protocol, sometimes we also give them follow-up that is typically 3 to 6 months based on the disease severity, treatment response, and individual risk factor before discharge to diabetic eye screening program. Now, regarding the new NICE guidelines 2024, when do we need to give anti-VEGF? So basically, if there is center involving diabetic macular edema with central retinal thickness of 400 or more than 400 micrometers on OCD, should be offered intravitreal anti-VEGF as a first line. And regarding the proliferative diabetic management options, again consider anti-VEGF as an alternative to pen retinal photocoagulation in selective patients, particularly those with better baseline vision or center involving DMO. And fenofibrate, this fenofibrate 145 mg that daily demonstrate that shows evidence for slowing diabetic retinopathy X progression in patient with type 2 diabetes and existing retinopathy. Now regarding can this system be followed in Pakistan or not? It requires some recommendation. Establishing our diabetic eye screening program in Pakistan requires many efforts across multiple domain. National screening program for all the diabetic patients maybe in Pakistan, we need a workforce development, can be non-medical graduates, as this system has proved very successful in UK because most of the guys working over there are non-medical. So, and require standardized grading can be followed up this system. Technology integration, yes, we need technology for these things. And even in the UK, they are using AI and they are using virtual clinic, which I will also explain. Now, regarding the take-home messages, escalating diabetic retinopathy burden, it is rising rapidly in Pakistan, and we need a system like this to prevent an epidemic of avoidable blindness. Enhanced diabetic precision. We need more of this imaging. We need more of this technology that can be used in rural areas. And we need optimized care pathway, and we need a system like diabetic eye services and hospital eye services referral that can reduce unnecessary hospital burden, and prevention through detection, early detection of sight-threatening diabetic retinopathy through systemic screening combined with timely evidence-based intervention can preserve visions and transform life while reducing healthcare cost. Now, what are the barrier for diabetic retinopathy in Pakistan? Screening program in Pakistan, limited infrastructure, low awareness, cost barrier, personal shortage, fragmented care systems. Now, these models are not only in Pakistan, in UK. These models are also used in some other countries. In India, it is Vision 2020 and diabetic retinopathy. Sri Lanka is national initiative. Bangladesh is community model. Key learning for Pakistan that we have to prioritize scalable workforce training, foster community engagement, and to ensure robust government policy and integrate technology like telemedicine for widespread reach. Now, regarding the role of technology and AI in diabetic screening. So basically in UK, we have something that is called as virtual clinic. So what is a virtual clinic? A patient will come. We have different diabetic eye screening centers over there. Patient will come, nurses will check the visual acuity, nurses will check the pressure. Patient will just undergo imaging that will include OCT and the ultra wide field images. Now patient will go home. All of these things will be given to the doctors. Now doctor will be sitting at home, will look at all the scans, and if they think that this patient needs to be seated face to face, they will call the patient. Otherwise, just a routine appointment. Now we're doing some of the work regarding the AI. So the audit that we are currently working on it. So basically, we are collecting a data of 100 to 200 patients, which includes their OCT, ultra wide field imaging, visual acuity, intraocular pressures, and we are using some of the AI algorithms. So we are giving the anonymized data to these AI algorithms, and then we will look at the response of AI, and then we will monitor or we will compare the management and diagnostic procedure of AI with the doctor, how successful it is. And if it proves successful, there is not a specific AI algorithm for diabetic retinopathy, but maybe in future, maybe the virtual clinics that we are doing can be replaced by AI. Now,
time is short, please.
this last slide, I'll be doing. Yep. And the same thing, telemedicine and remote grading, the virtual clinics I was telling, and electronic health records, that we should have a system which includes the health records of the patients, of all the follow-ups. That would be easier for everyone. And cost effectiveness and scalability by automating process, expanding reach to remote population, and optimizing resource allocation. These technologies can significantly lower per patient screening costs and allow for massive scalability across the entire diabetic population. Thank you.
Right, so I'll invite questions for any of the presenters of the and for any article. Shahzadi, I was very impressed with your presentation. Such a junior level, I think it's such a good start for a presenter or a trainee to start presenting at this stage. Believe me, however senior you get, the most you learn is from your own presentations. So wo jo ek tension hoti hai na, and it's very encouraging to see people so young get into this. Solar retinopathy, excellent presentation. I have never seen tandoor wale ke saath associated. So that to me is the first. I mean, to have that sort of light exposure just from a tandoor it's new to me. Anybody else ever seen this sort of ellipsoid zone disruption with?
I think the important thing with that is such a broad-based source of light producing such a focused, lesion. That's unusual. But one of the things that I've seen is young people who are using stimulants. They get into this phase of competing with each other to say who blinks first, looking at a candle at a short distance. And they end up in bilateral, light-induced damage to the fovea. But appearance is very typical, very pinpoint lesion going right down to the RPE level. That was an interesting thing in young people. Don't ask them the history. If you see somebody young and they said we haven't been looking at solar eclipse or anything like that.
Yeah. And it's also, it just draws your attention to the amount of PRPs that we do. I mean, here we are telling everybody else, don't look directly at the laser light. Like in hum log bhi to, so there's quite bright flash of light when you're doing PRP, even from the performer's end.
Yeah, but the filter's built in, so the operator is pretty much protected.
It's safe. And another thing that I wanted to, from my own experience, that initially there's a ellipsoid zone defect, and it's very hard to miss when you say, especially when you're doing OCTs. With time, I feel like these defects tend to turn into this non-specific sort of RPE change with a little bit of thinning of the outer nuclear layer in the long run. So if the patient is to miss these findings in the acute stage, and he presents to you, say, 6 months after or a year after, it gets very, very confusing. वो भूल चुका होता है कि मैंने कुछ किया था या कुछ देखा था, और वो उसकी फाइंडिंग्स बिल्कुल ये इस किस्म की क्लियर कट रहती नहीं है. मैं जस्ट टिप फ्रॉम माय ओन, आई हैड वन पेशेंट हु, उसके योगी मास्टर ने कहा था सुबह उठ के सूरज देखा करो, तुम्हारी आंखें बहुत अच्छी हो जाएंगी. दिस हैज एक्चुअली हैपेंड, एंड पढ़ा लिखा बंदा सर. Bilateral ellipsoid zone
But
defect.
forgot to tell him don't stare at it and try to blink in between.
He actually encouraged him. His yoga master actually encouraged him that you must look into the rising sun every morning.
One of the point for trainees is exposure to laser lights, because some of these laser toys, they have really, really strong, laser beams. So be very careful about that.
So, any other questions regarding his before we move on to calcification in the eye paper? I think posterior subtenon का था आपने.
Sir, it was a posterior subtenon triamcinolone injection. That was given along with the intravitreal
Faricimab.
faricimab.
Yeah.
Yes, sir.
So I've seen quite a few cases of calcification and osteomas, but thankfully nobody with choroidal vascular membrane. And did you find any other pathology, any other calcium deposits in the body, fellow eye, any problems with the parathyroid?
Possibly, yes. Your Ballard की जो pathophysiology, जो list of conditions that can present as this is, you mentioned tuberculosis and syphilis and sarcoidosis, बहुत varied है. So look for Ballard, recognize Ballard, and see its pathophysiology, where exactly the split is occurring. And so this just recently happened to me. And I was very, very, it just, when you're in a busy OPD and you see that sort of fibrinous, serofibrinous, multiloculated detachment, you're like, VKH. Yeah. I did. But then just that Batman sign aata hai na, acute CSR wala. I think it was just like a distorted sort of because acute CSRs mein fibrinous deposits hoti hain within the early cavity. And that just, I don't know what I was thinking, but I did. And then I had to discontinue this. I to delta cortil 1 milligram kg per body weight. And he came back after 10 days and I, so mistakes do happen. Any other questions on VKH? That brilliant presentation. They're all good enough, right? I haven't worked with NIDIC as such, but I wish, again, being in Pakistan, there was a time where now people are moving on to newer OCT machines with softwares that interconnect them to the rest of the world. So if you have a new module for Heidelberg Spectralis, it's easy for you to connect to every single Spectralis unit, because for research purposes, they're making it even more, user-friendly. But obviously, हमारे लिए वो एक investment then becomes too much of an investment with very little return, because so for somebody has to buy it, तो वो added जो आपको पता नहीं कितने लाखों करोड़ों देने पड़ेंगे for such a unit, वो उसका return नहीं है ना सर. तो इस वजह से फिर I think we're going to, because I went to England in 2017 till 2018, 2019. I was very happy to see we were up there when it came to, I was already working on OCT angiographies. Already we had, frankly, better surgeons than we did यहाँ पे, क्योंकि वो experience इतना ज़्यादा, exposure इतना ज़्यादा है. लेकिन अब जहाँ दुनिया जा रही है ना, and we're falling behind on this research, I fear for, Pakistani, we should be more research friendly. That's where the world is headed. We have more and more robotics and AI coming in, doing stuff that we're doing. We have to get on that bandwagon. But I wish, inshallah, that we, go up to speed with that.
Even now, Indian, there is some, some new one also. They are great, they are little bit you can find only the color of the image, sometimes like this, but everything that you want to diagnose.
Band जो कि extend कर रहा है from the type 2 into through to the CPHF, वो band invariably इनको अपने सारे they did 15 cases, तो उनको सारों में नज़र आया था, but CPHF उनको 2 cases में नहीं नज़र आया था. So he said that we could have named it type 1, mixed type 1, type 2 with CPHF, but we couldn't because of the 2 cases जिनमें CPHF नहीं था और HOB था. So he says that it's more of a vitreoretinal macular. So उसकी जो terminology थी, फिर he finally went on to name it type 4 MNV. Analysis में आपको anastomosis तो नज़र आ रहा है, but you're not exactly sure as to where it's originating. So again, so we feel like somehow the other will land at this bidirectional relationship. So the CNV is somehow influencing the vitreous, the vitreoretinal interface, and then consequently the VRI abnormalities are then influencing the fibrotic process, because ये वाली CNVs are very advanced. Allah जानता है. Would say that is because इतनी severe lesions में आपका OCT ऐसे ही fail कर जाता है, projection errors इतने ज़्यादा उसमें हो रहे होते हैं. So probably that's the reason why I was working on OptiView Avanti at the time, but I didn't find, and I didn't have it on all my on all my cases. So I couldn't cite it as a consistent research methodology. That is where it lacked. Saraf, obviously you're working with sort of those prototype research-based OCT angiography machines, so probably better segmentation and slab उन्होंने उठाए थे. He was able to elucidate CNV lesions within this CPHF in all of his cases.